Hello guys, welcome back. So I'm back with one more topic, and this is supposed to be the most important topic, most favorite topic of the students as well as the examiners. So you're not going to miss this class at any cost. Hope you're already waiting. There was a slight technical problem because last class you have all complained about the voice problem. No, the sound quality was not so good. The voice was breaking in between, so we have to just adjust it between, and so because of that there was a 10 minutes delay. Sorry for that. So now we are all ready for the class. So now can you confirm whether the audio is good? I hope the video is good. Yes. So if the audio and video is good, not delaying further, let's get started, right? So this class I have explained that this is today we're going to deal about the peripheral nerves. So examination of the peripheral nerves is the topic for the day, and this is most important topic because one or the other case will be regarding your peripheral nerves. And you all know that claw hand is very important. So it could be a claw hand, or it could be a wrist drop, right? And it could be a foot drop. So these three are the important questions which are usually expected, right? So let us not further waste our time. So the voice is not breaking now, no? Hello. So coming to the examination of the peripheral nerves, the first thing what you have to remember is, now today we are dealing with, yes, thank you so much. Sorry, I'm unable to pronounce your name, but thanks for that. So history of presenting illness. So coming to the peripheral nerves, the most important thing, what would be the history of this is mostly they deal with trauma, right? So mostly there would be a traumatic injury, which could be a blunt injury, or which could be a penetrating injury, right? So injury is very, yes, Dhruva, hi. So this could be two important things which we come across in case of peripheral nerve injuries. One is the blunt trauma. The second one would be a penetrating injury. So these two are very important. So whenever you talk about peripheral nerves, the first thing coming to the history, you have to always include trauma first, right? And then this trauma could be an indirect trauma also. So it could be a direct trauma, as I've told you, it could be a blunt or peripheral, or it could be an indirect trauma. So what are those indirect trauma? You all know in case of your peripheral nerve injuries. So coming right from the anterior dislocation of the shoulder. So which nerve is mainly affected in this? Anterior dislocation of the shoulder. Which nerve? Faster? Let's not waste much time today because we have a lot to deal. So here comes your axillary nerve. So whenever a patient comes with the shoulder dislocation of the anterior shoulder dislocation of the, you have to look for the axillary nerve, right? And then coming to the, yes, very good, axillary. And then what is the posterior dislocation of hip? Which nerve you suspect in posterior dislocation of hip? Quick. Yes, very good. Then medial condyle of humerus. Then supracondylar fracture humerus. So here the sciatic nerve, very important. And then medial condyle of humerus. Which nerve will be affected in medial condyle fracture of humerus? Faster. Very easy. No, it is ulnar nerve. Yes, then the supracondylar fracture humerus. So medial side of the humerus, elbow class, if you have attempted, we have told you very clearly that the ulnar nerve passes through the medial condyle, right? So whenever there is a medial condyle fracture, you have to take care about the ulnar nerve. Then what about the supracondylar fracture? Supracondylar fracture, yes. This is very easy, you should know. The first one is, yes, AIN, then median nerve. No, it is not radial again. It is again AIN median. Okay. So I'll ask you the question for which the answer is radial nerve. So when it is shaft of humerus fracture. Humerus shaft fracture or your favorite Holstein Lewis fracture. Then which nerve will be injured? Yes, now I want you to answer. Yes, radial nerve. Very good. Yes, now it is the radial nerve. So these are the nerves which you have to remember. And see, whatever case they give you in the exam, that doesn't tell you that this is particular nerve which has got damage. They will tell you that this is a case of shaft of humerus fracture. So whenever you go back to the patient, he might present you with the wrist drop. So whenever there is radial nerve palsy, what usually they present with? They present with wrist drop, right? So once the patient comes with wrist drop, you have to take the history. So what history you will ask? You will ask the traumatic history. Was there any trauma happened to this particular hand which resulted in the wrist drop? Then they will tell you that long ago or 6 weeks or 1 month they had this trauma, that is fracture humerus. Or they will tell you that one night I had couple of drinks and then I slept in this position which is called a Saturday nerve palsy, and then he has resulted in this wrist drop. So this is how you have to go back and take the history, so that they whatever deformity which they're presenting with, you have to know which nerve is damaged and then take the appropriate history. Like for example, I've told you the wrist drop, then you have to ask about the shaft humerus fractures. And if they come with the median nerve palsies, median nerve palsy, what do you see? You see the pointing index, right? So the patient comes with the pointing index, then you ask him regarding the history of any fracture which is occurring in the distal humerus. Then sciatic nerve, they come with the foot drop, and then ulnar nerve, they come with the claw hand, and axillary nerve, they come with the deltoid paralysis, right? So this is all what the patient will show us. So this is what the patient complaints will be, right? See, for this particular things, how much homework you have to do, right? So the patient will complain about only foot drop, the claw hand, pointing index, and the wrist drop. Then you have to know why the deformity has occurred, which nerve will result in that deformity, and then what could be the mechanism of the injury, or what could be the fracture which would have led to this deformity. So this is all should run back in your mind, right? So that is why a very, very important topic, right? So that would be the presenting illness. Now you will ask about the trauma, and then if at all not trauma, the second one could be a malignancy also. So there could be a malignancy where the patient complains about some swelling or there was some problem, and then this has resulted in so and so injury. And then it could be some compressive myelopathy, right? So it could be some compressive syndromes like your carpal tunnel syndrome, right? So in that, the patient comes only with the symptoms of median nerve palsy, because which nerve is involved in carpal tunnel syndrome? It is the median nerve, right? So she will come with only complaints of median nerve. Then you have to imagine that because of this carpal tunnel syndrome she's having. So then you will ask her history regarding the carpal tunnel syndrome, like when this pain had started, what happened to her and all. Then it could be because of any infections such as your herpes zoster infections, right? Herpes zoster infections, which will result in the severe nerve injuries, and then you will have this severe sensations like painful sensations, sensory sensations and all. So infections are one other cause which might result in the peripheral nerve damages, right? And then what could be the other reasons? Do you think of any other reasons other than trauma, malignancy, compressive neuropathies and infections? What else could be? So I will tell you one more interesting things are, see, sometimes they give injections, right? When they give IM injections, intramuscular injections, so this will also result in paralysis, such as your deltoid paralysis, injuring your axillary nerve or the sciatic nerve, right? So this history of injections can also be one of the cause, not all time, one of the cause. And most common injections, quinine injections, right? So this was used extensively for malaria, right? The quinine injections. So this also will result in palsies, right? Nerve injuries, right? So this is about the history taking. So you will put up everything which will related to that nerve palsy and you will compile a history. So this particular history could be just a presenting illness, or sometimes it could be related to your past history as well. So for example, if it is a tardy ulnar nerve palsy, so let us take the example of tardy ulnar nerve palsy. So what is tardy ulnar nerve palsy? Where do you see this? Tardy ulnar nerve palsy, where do you see? You see in the lateral condyle fracture of humerus, right? So what happens in lateral condyle fracture humerus? So it develops in a deformity which is called as cubitus valgus, and because of this valgus deformity there will be stretch on the ulnar nerve, and that results in your tardy ulnar nerve palsy. And now in the presenting illness, the patient will tell you only about the fracture, right? So he has so and so fracture, and he has because this will take at least 6 months to 1 year to develop, right? So it is a very prolonged process. It could be 2 years also. So then he will tell you that it has been what is the progression of the deformity, what is the time of the deformity, and in the past history you will ask about the fracture, the treatment protocol to it, right? You will ask about the treatment protocol, what has happened, how did it immobilize and all. So this is how you have to present with presenting illness and past history. And remember, in orthopedics, what we do, we only take the positive points, whatever we are, which can lead to your diagnosis, only the positive points and few negative information. That's it. Okay. So then whenever it is a fracture, you will ask whether it is an open fracture or a closed fracture, because in an open fracture, again, there could be a penetrating traumatic injury. So this is how you put forward the history. This is how you take the history and you will compile everything, right? So this is about the history taking, right? Then coming to the examination. So always the examination starts with inspection, palpation, and then your movements, right? So usually we don't take any measurements here, so inspection, palpation and movements. But here, because we are doing a peripheral nerve injury, because this nerve will have both motor and sensory, right? So motor, you have to examine the motor, that is your muscle power and individual nerve muscle testing. And for sensory, you will look for all the sensations, like your touch, your pain, vibrations and all. So that completes your complete examination, right? So let us see what all we see in the inspection. So always in the peripheral nerve examination, the inspection starts with the attitude and the deformity. So here nothing much to do with the attitude except for it is a trauma, but deformity is very, very important, as we have seen a lot of deformities, such as wrist drop is one such deformity, then claw hand is one such deformity which the patient can present with, then foot drop is one more deformity, and then he can present with pointing index, which is not actually a deformity, but usually they complain that this finger is not working properly, or there is a problem in this so and so area of the hand, right? So these are all the deformities which the patient can present with, and we have already seen the reasons why these deformities occur. So you will you will note down or document this deformity, such as, patient is complaining of so and so deformity, and you will document it. That is only by inspection, right? Only by inspection you will write what type of deformity is patient presenting with, right? And sometimes you can see in the deltoid paralysis, you can see that shoulders are not at the same level if he's complaining at the, drop of the shoulder level, right? In case of your deltoid paralysis. So that is how you will describe the deformity, right? And then the most important thing what you see in inspection in case of the nerve examination is this. This is very, very important. What we see what is called as wasting of muscles. So because all these are little bit chronic lesions, right? So they develop wasting. So you have to look for the wasting of the muscles. Like for example, if there is a ulnar nerve palsy, then you will see wasting of the interossei muscle, right? And if it is a radial nerve wrist drop, you will see wasting of these muscles, right? So such like that, you have to describe which muscles are wasting. So usually because of the atrophy, you see this wasting of the muscles, and you have to document it, which nerve is leading to so and so wasting of the muscle. Then you have to look for the skin, because again the nerve is related again to various sensations. So you will see whether the skin is dry, because without the absence of the nerve connections, it becomes dry, right? Sometimes the skin becomes very dry, and you have to look for the wounds. I have told so there will be a chances of penetrating injuries, so you have to look for any wounds which are present there. So on the skin, if there are any wounds, and then they can complain about decreased sensations. So this again you will test in the palpation, but sometimes on the inspection you see that there is loss of hair, and the skin is dry, and all those things, right? And then scars and wounds. Again, I have told you, right, these wounds and scars, it is very, very important, because this nerve injuries are mainly occur as a result of some traumatic some trauma which is occurring around that particular joint where the nerve is present, right? So for example, if it was an open fracture, then you will see a wound, right, or a scar. So this scar sometimes get adhered, right? So adhesions of this scar, right? So these are all you will look for in case of inspection. So first would be attitude on deformity, you will write, and then you will write about the wasting of the muscles. Then you will look for the skin. How is the skin present? Is it dry, or there is no hair which is present? Absolutely. Or there could be any wounds, right? Contracted wounds or contracted scars. And again, you have to elicit even for the scar tenderness in case of palpation. That we'll see in case of palpation, right? So this is open fracture, scars and wounds. So that is about the inspection. So how do you inspect in case of your peripheral nerve lesions, right? Then comes the palpation. So palpation, what we actually do is, usually we see the temperature, whether hot or cold, right? Hot or cold, the patient is feeling more hot, more cold, what is it? So that is about the temperature. Then again, skin, here you examine for the, okay, scar I have written it again. So here for skin, again you test for the dryness, loss of sweat, or any skin conditions, any skin lesions, right? So you check for all those, and whatever you see, then you will palpate it and write. And then muscles. So here muscles, you have to look for the tone of the muscles, right? You will palpate and look for the tone of the muscles, whether the muscles are flabby, right? So you will usually look for the tone, because nutrition we will see whether it is atrophied or not. So that is weakness. So there we will document how is the muscle. So wasting of the muscle is present or not. Here you actually touch the muscles and you feel the tone of the muscles, whether they are good or they look flabby. That is called the tone of the muscles. And then again, I've told you about the scar. So you will see any scar or wounds which are present around, and also you will look for the scar tenderness sometimes. The scar tenderness also you have to document. So this is about the inspection and palpation. So these are just the terminologies which you have to remember. So you are going to document the in inspections of main important thing is in inspection you're going to write about the wasting of the muscle, because deformity anyhow you will write. So deformity, wasting, skin. That is very, very important. In skin only it comes the scars and the wounds. And then palpation, you will look for temperature, skin again dryness, again wounds and scars if they are present, you will document it, and then you will look for muscle tone, right? So this is how you have to write for the examination, right? And then this is very, very important for us. So muscle power. So once we are done with the inspection and palpation, by now we will know which nerve we are going to test. So you're going to put some of the important muscle testing. So not all the muscles, but some of the important muscles which are supplied by that particular nerve, you're going to do the muscle testing. Sometimes individual muscle testing. So for example, if it is an ulnar nerve, so you will examine for the introosseous. So there are two introosseous, palmar introosseous and the dorsal introosseous, right? So what is the test for palmar introosseous? Yes. Lot of listening is done. Now time for answering. Which test is used for testing the palmar introosseous of the ulnar nerve? This has been taught in the anatomy first year. Yes, Dhruva? Palmar introosseous will cause what? Adduction. This is tested by which test? Faster, come on. Very easy. Card test, right? Exactly opposite. Palmar is adduction. Adduction is by card test. Then, so I will ask you which is 𝐒𝐿. So dorsal introosseous tested by? Yes. Now you have to answer me right. So dorsal introosseous is for abduction. Abduction is tested by which test? Now, 𝐒𝐿. Good. So here, remember, see, don't get confused. What did I tell you? I told you we are going to test the palmar introosseous. What does the palmar introosseous do? The palmar introosseous do what? So now, so this is the card. Yeah, 𝐒𝐿 dorsal, correct. So this is the card, right? So now I'm holding this card and I am doing what? Adduction, right? So holding of the card is adduction. Then what is 𝐒𝐿? 𝐒𝐿 is abduction. This movement is called the 𝐒𝐿 movement. That is abduction. That is by dorsal introosseous. Okay, good. So that is how you test for individual muscle testing in case of your any nerve palsies. Then each individual muscle, when you test, you have to grade them. So how do you grade them? Which grading system you take? MRC grading by London, right? Right, in that there are 5, right? 1, 2, 3, 4 and 5. Now can you tell me what is 0? So this also they will ask, what is the grading system you have used? It is MRC. Okay. And then 0 is what? 0 is complete paralysis, right? 0 is complete paralysis. So if there is nothing happening in that muscle, it is called complete paralysis. Then what is 5? 5 is normal, which is again full resistance. Against full resistance, right? So 0 is complete paralysis, 5 is against full resistance, right? What is MRC? Medical Research Council. Okay, Medical Research Council, right? So MRC is Medical Research Council. Then what is 1? 1 is flickering. Flickering of muscle. Then 2 is eliminating gravity. Then 3 is against gravity only. And 4 is against gravity and some resistance. So how do we test this? We have written it neatly, you know, theory. This is theory, but how about practicals? Practicals is more important, right? So once you go back and now just see the wrist extension. So let us tell that we are dealing with the wrist, for example, your some individual muscle, right? So here what we are doing is, so we are asking the patient to flex the elbow, right? So we are asking the patient to flex the elbow. So that is the action which you have to do. So if he's completely not able to do, then that is complete paralysis. Then you put the grade as 0. Then if he is doing some flickering of the muscle movements, if he is trying to do and there is some flicker which you can see, you know, not exactly able to make out, that not complete paralysis, then you will write the grade 1. Then what is eliminating gravity? Grade 2 is eliminating gravity. So eliminating gravity is sideward movements, right? So patient is able to shift this side to this side. So he's able to do some sideways movement, sidewards, right? So that is called eliminating gravity. Against the gravity is grade like this. If you're not putting any resistance and he's just able to do like this, then that is grade 3. Right? And now grade 4 is he's able to do like this and you're able to put some resistance. Some resistance is grade 4 and full resistance and patient is able to do is 5, normal, right? So that is how you have to grade them, right? Remember, once you go to the patient, first you will ask them to flex. So this is against gravity. So directly you will go to grade 3. If he's able, if is not able to do against on his own, right, against the gravity only, then you can do the sidewards and 0, 1, 2. If he's able to this, directly do this, then you will start from 4. That you will put little resistance and then you will put your full resistance, right? So that is how you have to test for grading the muscles. That is individual muscle testing. Remember, if you could do for all the muscles, that is very, very good. But usually it is a short case in ortho, right? So you have to remember those important muscles for each nerve and then you can do only those 1 or 2 muscles. That would be enough, right? Okay, then that is about the grading of the muscle. So that completes the muscle. So we have done with the nutrition, that is you have told the atrophy, that is wasting of the muscles. Then we have checked for the tone of the muscle. So tone is hypertonia, that is tone of the muscles. And then we have checked for the power of the muscle. So power is by grading. Then you will come for the sensory system. So without testing of the sensory, it is usually not complete. So whenever you want to complete the peripheral nerve examination, you have to have both motor and sensory. So motor is about muscle testing. So now comes the sensory. There are 5 or 6 things which you have to test in case of sensory. So first is the tactile sensitivity in case of sensory. So what is that? So first one is your fine touch. And the second one is your crude touch. And then third one is your 2-point discrimination. 2-point discrimination, right? So what is fine touch? Now it is all your general medicine, you know, you have to help me out here. So in case of fine touch, what you do in fine touch, first all these things you do at the course of the nerve. So for that you have to understand which area is supplied by which nerve, then only you will do all these testings at that particular area, right? So here fine touch is cotton wisp. So we use the cotton, right? And then we touch. So that is comparative. Again, you have to take 2 hands and then you put the cotton, strokes slowly. I mean that softly you have to do, and then you can feel this. The patient will close his eyes and then you will feel that cotton touch. Thus, that is the fine touch. And then what is crude touch? Crude touches you can do by your finger directly. So little pressure, that is crude touch. And 2-point discrimination is this. You use the calipers, which are, you know, 2 straight objects like sharp objects, and the patient has to discriminate the distance. So at least 2 centimeters wide, he has to discriminate, like 2-point discrimination. So that is one of the tactile sensitivity which we usually test for the patients in case of peripheral nerves. So fine touch, crude touch, and 2-point discrimination. And then comes the pain. So pain, again, we have two things, right? Superficial pain, and then we have the deep pain, right? Both superficial pain and the deep pain, both you have to test. Superficial pain is just pinprick. Pinprick is superficial, right? So deep pain is something which is coming from inside, such as, you know, bone pains like that. So you will test for both the things. So you will test first for the touch, that is fine touch, crude touch, 2-point discrimination. Then you will test for the pain. So if the patient is having pain in that particular sensation, or if it is completely anesthetic, so there is no pain, no touch, so what is the sensations which are patient been experienced in that particular area. So that is about the pain, right? And then we have temperature. So here we use 2 test tubes, right? So one is hot and the second one is cold. So again, you will touch the hot and the cold and ask the patient to feel it, whether he is able to feel the hot and cold sensations. So that is about the temperature. And then you have the recognition of the shape. This is called anisognosis, something like that, you know, constant pronation and supination they will do. And sometimes you give them something in the hand and they are able to recognize that. So that is the recognition of shape. That is again the sensation. So you give any shape or you ask them to do supination and pronation, right? So that is how we do it, right? So that is the recognition of shape, size, form of the objects, right? And then position sense. So this position sense and vibration, these are again by the dorsal column. So testing of the dorsal column. Position sense is you have to ask the patient, you have to put in some position and then you have to ask whether you are moving the joint or not moving the joint, or what is the position of the joint. So this is the joint position, they have to sense it, right? So this is proprioception, something like the proprioception. Then comes the vibration. This you know better. So we use the help of the tuning fork, right? And then we place it on the particular area that is around the joint, and then we ask if the patient can feel the vibrations or not. So this is again a test for the sensation. So these are all the tracks which we are examining. So you will start, so you have to put a column like this, right? So always it is comparative. So if there is a right side, left side, then you'll put right side, left side. Then you will write sensory examination. And then you will write all this. So first you start with touch. Then you start with pain. Then you start with temperature. Then you start with position. Right? And then you put vibration. And then recognition of shape. So this is how you have to put the tabular column, right? It is not like each thing you will write separately. You have to make a tabular form and then you have to write, right? So this is how you will put the sensory examination in detail for the patients. And you will always end with reflexes. So reflexes are very, very important. So you have to understand if it is a foot drop. If it is a foot drop, so you're dealing with the sciatic nerve. So the reflex is S1 and S2, that is ankle reflex. So then you will write the ankle reflex, whether it is sluggish or it is plus or plus like that. Okay, so that is how you will code for the reflexes. Again, you have to put the tabular column and then you will write the reflexes, and you're checking for the quadriceps and ankle or plantar, right? Right, and then you will write right and left. And then you will put, if it is sluggish, it is more, if it is more, like that you will write, right? And that is about the reflexes. So you have to always understand which reflex is meant for which particular nerve, and you have to put that reflexes as well. Then finally, you will end up the movements. So movements are very, very important. Again, not to tell you completely, there are 2 types, active and passive. So active movements and passive movements. So usually active movements and passive movements will be the same if there is no problem with it. But sometimes because of the adhesions, bony adhesion sometimes, right? So both can be decreased. Sometimes active will be less, passive will be more, because of the most relaxation of the muscles around it, right? So you have to put up both. So you are going to test for the active movements, and then you're going to test for the passive movements and document both, right? So this is how you complete the movements. So that is how we will test. So this is the pro forma. So for peripheral nerves, what I have done is I have put the pro forma first. So because pro forma is very, very important, right? Because I know everybody will ask you about the car test, book test, and all that test theory. You will be a little bit okay with the peripheral nerve examination, because we usually, that is the important questions, no, for radial nerve, palpal nerve, you keep on reading, so theory you will be a little bit okay. So that is why the examiner will concentrate on the pro forma. He will ask you what are you will test and what you will. So that is why I have written pro forma here, right? For other examinations, for example, malunion. So malunion, most of the things, there is nothing for you to ask at your level. There is nothing for you to ask, what are the various surgeries which could be done, and malunion is little bit easy, Colles fracture. So that time they will ask you the theory most, because there is nothing to write in the pro forma. You will write the deformity, movements and measurements, only little is there. So that's why theory is important here. Because of the peripheral nerves, there is a lot to write and document. So you have to start from what had happened to the patient, how did they land up here. So this is the pro forma which you have to follow. Done. And now we will come to the individual nerves, right? So now little bit of theory we will learn. So this is, I will teach you again, this is theory part again. So what you have to learn, so you will start, they can ask you right from what is a neuron, they can ask you what are the nerve injuries, right? And what are the different classifications of nerve injuries, right? And then they can ask you how do you what are the various things. So I will start right from the brachial plexus. So you all know what is brachial plexus. So it is C5, C6, C7, C8 and T1, right? And you know what is upper trunk, right? And then you know what is lower trunk. These two are important for us. Why upper trunk and lower trunk is important? Because there are deformities associated with this. So whenever there is damage to this particular upper trunk, we are landing up in a deformity which is called as Erb's palsy. So what is this Erb's palsy? Your favorite deformity? Policeman tip deformity. Right? So policeman tip deformity. So what is Erb's palsy? Policeman tip deformity. And now what is lower trunk? Yes. What is the lower trunk injury called as? Yes. Lower trunk injury, C8 and T1 will result in what paralysis? Erb's palsy is upper trunk. Lower trunk is? Very good. It is 𝐒𝐿-case. 𝐒𝐿-case is lower trunk, right? So what deformity you see in 𝐒𝐿-case? Here it is policeman tip deformity. In 𝐒𝐿-case it is what? Whenever there is damage to C8 and T1, what deformity you see? Yes. Yes, Dhruva, what deformity we see in 𝐒𝐿-case? C8 and T1 is what nerve? Ulnar nerve. So ulnar nerve, what is the deformity? It is your ulnar nerve is very easy. Claw hand, right? Yes, very good. So ulnar nerve is your claw hand. So this is the policeman tip deformity and this is your claw hand. Now let us see what is Erb's palsy. So this is your Erb's palsy. So here they can this put as your spotter. So what is this? Erb's palsy. Where do you see? It is usually see in the obstetric birth palsy, right? Shoulder dystocia means what will happen? So the obstetrician who is delivering the baby might, pull the shoulder where there is damage to your upper trunk, or sometimes the shoulder position will be there. No, they are delivering through the shoulder position, or the head might get stuck and they pull the shoulders. So whatever is there, that is during the delivery, they will damage our particular upper trunk, that is C5 and C6, right? And this will result in this deformity. So what is this deformity, what you're seeing here? So first there will be adduction because there will be damage to the deltoid, right? And then what you see? You see the internal rotation, right? Adduction and internal rotation, and the elbow is in what? Flexion or extension? Yes? Elbow in extension and pronation. Right, so this is the deformity. Very good. So there is adduction. So look here. So there is an adduction because of loss of deltoid, internal rotation, and then you see elbow extension with pronation. So this is C5 and C6, C7. Again, the damage of the musculocutaneous nerve, right? So the musculocutaneous nerve supplies the flexors, elbow flexion and supination. So because of the damage to that particular musculocutaneous nerve, there is elbow extension and pronation. And because of damage to the deltoid, that is axillary nerve, the teres minor, which is again useful for the external rotation, is also damaged. Hence, we have adduction, internal rotation, extension and pronation. So all this will lead to what? Your policeman tip deformity. So this is how the waiters take the tip, right? So they will ask you to give from behind. So that is how the policeman tip deformity has come up. So this is your Erb's palsy. So these are your deformities which we see. These deformities is because of damage to so and so nerve, right? So the axillary nerve, the musculocutaneous nerve, the axillary supplies the deltoid and the teres minor. Deltoid is for abduction. So there is loss of deltoid. So patient is in adduction. Teres minor is for external rotation. That is also loss of internal rotation. So musculocutaneous is for your flexion and supination, right? Then there is loss of flexion which results in extension and supination which results in pronation. So this is your Erb's palsy. So this can be your spotter, and then they will ask you how this will happen, what are the deformities. That's it. Okay. And then 𝐒𝐿𝐾𝐝's palsy. So 𝐒𝐿𝐾𝐝's palsy we have already discussed. It is lower trunk, so C8 and T1. So whenever there is damage to C8 and primarily there is ulnar nerve which is involved, right? So this ulnar nerve will result in what? It results in claw hand. So what is a claw hand? Can you describe what is a claw hand? Yes? What is clawing? So this clawing is basically because of loss of lumbricals and interossei. Yes, DIP flexion, PIP. So this will result in MCP. What will happen to MCP? Extension or hyperextension with IP flexion. So this is your clawing. This you have to remember. So what happens in the claw? This is claw. So MCP, and that is C8 and T1. So ulnar nerve which is supplying your little finger and the ring finger, right? So now there is, if you see, this is extension of MCP, and then there is flexion of your IP. This is your flexion of the IP. So this is your claw hand. Okay. That is because of your 𝐒𝐿𝐾𝐝's palsy. So this is your 𝐒𝐿𝐾𝐝's palsy where the patient will have your claw hand. Okay. And then what is the splint which we use for this palsies? So brachial palsy splint. Which splint is used for brachial palsy? So what is this splint called? If you see, we have put this in opposite. So there was adduction and internal rotation, right? Now we have put it in abduction and external rotation, right? So abduction, we have put it in abduction, and if you see, elbow is in flexion. Elbow is in flexion. So what is the splint named as? Yes? Faster? Very, very easy, very, very important. This splint is named as aeroplane splint. So the splint which is used in brachial palsy or brachial plexus palsy is your aeroplane splint. So what is the position? You see there is the shoulder abduction and elbow is in flexion, right? So that is your very good aeroplane splint. Good. Then spinal accessory nerve. So what is the spinal accessory nerve for? It supplies what? The trapezius muscle, right? It supplies the trapezius. And what do we do? What is this called? It is helpful for shrugging of the shoulders. So the action of the spinal accessory is shrugging of the shoulders. Yes, shrugging. So whenever they come with the spinal accessory nerve palsy, so you will see that there is a drooping and they cannot shrug the shoulder. So what is the test we do? The testing is shrugging of the shoulder, right? That is your spinal accessory nerve. And then long thoracic nerve of Bell. What is this? Again a spotter. What is this arrow mark? It applies to serratus anterior muscle. Very good. Serratus anterior muscle, and this is called the winging of scapula. Very good. This is winging of scapula. So how do you do this? The test is pushing the wall, right? And now you can see the medial border here. The medial border becomes prominent, right? So whenever there is a weakness in the serratus anterior muscle, so you will ask the patient to push the wall as if he is pushing the wall. And then what will happen? There will be medial border will be prominent. This is called winging of scapula. This is called winging of scapula, and this is mainly for the serratus anterior muscle testing, or which is called the long thoracic nerve of Bell. Long thoracic nerve of Bell, right? So that is about the long thoracic nerve of Bell. So a spinal accessory we have discussed, that is shrugging of shoulders. Then we have discussed long thoracic nerve, that is for serratus anterior, which is called as winging of scapula. How do you test it? You test it with pushing the wall. Then comes your musculocutaneous nerve. Musculocutaneous nerve, if you see, this is your musculocutaneous nerve here, right? And this applies the biceps. I have told you, right? Biceps, and it is mainly for flexion. Flexion and supination, right? So it applies the flexors and the supinators. So that is your musculocutaneous nerve. C5, C6 and C7, right? So that is your musculocutaneous nerve, right? This. So you have to test for the flexion, that is biceps, flexion of elbow, flexion of elbow, right? So that is your musculocutaneous nerve. And then very important, axillary nerve. So which muscle is supplied by this axillary nerve? Axillary nerve supplies your very important deltoid. And it is very important to understand that it supplies a small portion of the skin Yes, small portion of the skin over the deltoid, and this area is called the regimental badge area, right? So it supplies the deltoid muscles, and the action of the deltoid is what? The action of the deltoid is abduction. So whenever there is on inspection, what you see there is the deltoid curvature is lost, right? So the curve is lost, the shoulder curve. This shoulder curve is because of the deltoid. So that curve is lost on inspection. And this is your deltoid muscle, which is supplied by the axillary nerve. And it also gives a small branch to the teres minor. I have told you that is why in Erb's palsy you will have the internal rotation. And now what happens is, so this is called the regimental badge area. So this is the regimental badge area. So this is the area where you have to test for the sensations, right? So this is the area where you have to test for the sensations, right? So whenever you test the sensation, they will be decreased in sensation. So it will be hypoesthetic or anesthetic in this particular area. So this is called the regimental badge area, and it is very, very specific for the axillary nerve. So axillary nerve, you will remember, it is for the deltoid, right? And deltoid is for abduction. So there will be loss of abduction, and then there will be loss of that shoulder curve. So you will find something like drooping of the shoulder, and then this particular curve is lost. And then when you see for the sensations over this regimental badge area, it will be decreased in the sensation. So there will be decreased sensation, right? So that is about the axillary nerve. And then coming to your favorite three important nerves which you have to deal with. The first one is your radial nerve. Second one is the median nerve. The third one is your ulnar nerve. And the fourth one is the sciatic nerve. So this is all you have to learn whenever you're going for the exam. So this could be, even if they put up the case of ulnar nerve, they will ask questions regarding radial and median and sciatic. And if they put up radial nerve, they will ask all the nerves. It is very, very important. So coming to your radial nerve, all you know is it supplies extensors of upper limb, right? Especially the forearm. In arm, it supplies the triceps, and in the forearm, all the compartment, 6 compartment extensors we know, right? So all the 6 compartment extensors it supplies, right? So that is the radial nerve. And one important course you have to understand that it passes through the radial groove, and from piercing the lateral intermuscular septum, it enters the lateral side, and this piercing is at the junction of middle and distal 1/3, right? So this area is called your Holstein-Lewis fracture. So what is Holstein-Lewis fracture? Yes, fracture of humerus at the junction of medial 1/3 and distal 1/3, where it is piercing the intermuscular septum, the lateral intermuscular septum, which is associated with crushing of the radial nerve. That is your Holstein-Lewis fracture. Very, very, very important question, right? So usually whenever you come up with radial nerve palsy, first question they will ask you is about Saturday nerve palsy, because that is very, very important. And then they will ask you what is Holstein-Lewis fracture. So Holstein-Lewis fracture is, as I've told you, that this radial nerve, whenever it is coursing, it pierces the lateral intermuscular septum. There it is It is fixed to that particular area. So whenever there is a fracture at that particular area, because it is fixed in that area, it cannot escape. So it gets crushed between the fracture fragments, which is called as the Holstein-Lewis fracture, where you see the fracture of the humerus associated with the radial nerve palsy. Is that clear? And you all know that the radial nerve gives a branch. So what is the name of that branch? It gives a branch which is called the posterior interosseous nerve, right? So it is usually in the substance of the supinator. So the radial nerve is present in that substance, that which the branch, the pin is present in the supinator. So whenever we are dealing with the fractures of the proximal radius, so this area, whenever we are dealing, we have to be very, very careful that we may damage this pin. So this muscle is very important in terms of your posterior interosseous nerve. So they might ask you this question. So whenever there is, injury to the proximal radius, and if at all there is a, iatrogenic damage, which nerve will be damaged in that particular area? Because this posterior interosseous nerve, which is a branch of radial nerve, is present in the substance of the supinator. It could get damaged, right? So this is about so these are all the muscles which are supplied by your radial nerve, right? So this is, you have to remember. I mean, you have read everything in the anatomy, that you have to brush up, right? So in the arm, you have to remember only one muscle, that is your triceps. In the forearm, there are 6 compartment muscles, right? So those all 6 compartments you have to remember. And one thing, the branch of this radial nerve is your posterior interosseous nerve, and the importance of this is it supplies all the nerves in the forearm here, right? But it originates from this muscle, that is supinator. It is present in that substance of the muscles. Hence, during the operation of the proximal radius or in the proximal radius fractures, there is high chance of this pin getting damaged. So whenever there is damage to the pin, what will happen? It will result in finger drop. It will result in finger drop, right? So radial nerve will result in wrist drop. Pin will result in finger drop. Fine. And now, so now we are going to test the triceps, individual muscle testing, right? And then you can test for your extensor carpi radialis, which is supplying the wrist, and then you can examine the extensor digitorum, which supplies the finger, right? So these are the muscle testings, individual muscle testings, which you have to do for your radial nerve. So you will test for triceps, you will test for wrist extension. So everything is extension, right? You test for wrist extension, right? So triceps, extensor carpi radialis, and extensor carpi extensor digitorum for finger extension. So these are the individual muscles which you can test. So whenever there is a damage to the radial nerve, so this is what? So this X-ray tells you what? This picture tells you? Name this fracture. So what is the fracture name? Yes, Dhruva? Come on, faster. I have explained so much just now, no? Where you're seeing the fracture? This is a humerus. Humerus fracture. Where is it exactly? This is proximal 1/3, this is middle 1/3, this is distal 1/3. Yes, supracondylar is this, but the fracture is here. So this is humerus shaft fracture, junction of middle and distal 1/3. So this is proximal 1/3, I've told you, middle 1/3, and this is distal 1/3. So junction of middle 1/3 and distal 1/3 with the radial nerve palsy. You can see there is crushing of this radial nerve. So what is this fracture called? This is Holstein-Lewis fracture. Okay. Yes, very good. Holstein-Lewis fracture. Just now we have told you, right? And what is this? One more classical example of your radial nerve palsy. What is this? Yes, this particular individual had binge drinking on Saturday night and has fall asleep in this posture where there is, pressure into his axillary region. What is this called? Very famous, one thing which we read in anatomy. Yes, this is wrist drop. But what is this condition? What has led to the wrist drop? Yes, Saturday nerve palsy. So this is your Saturday night palsy. Right? So Saturday nerve palsy has this Saturday night palsy has resulted in the wrist drop. So what type of injury is this? So we have three types, right? Neuropraxia, axonotmesis, neurotemesis. So what type of injury is this? What type of injury is this Saturday night palsy? This is a type of neuropraxia, right? This is a type of neuropraxia. Yes. Not neurotemesis. It is a type of neuropraxia, right? So this is a classical example of Saturday night palsy where the patient will come next day with sudden wrist drop. And now he will not understand why he's having wrist drop because he knows there was no trauma which has occurred. But the thing is, there is a pressure, compression in the axillary nerve which has resulted in damage to the radial nerve. And now this has resulted in the wrist drop, right? Yes. And what is the treatment for this? Splinting. So radial nerve palsy. Treatment is splinting, right? Yes, 𝐒𝐿-𝐄𝐝 splint. Very good. So there are two types. One is your static. The second one is your dynamic. So which one is static? Which one is dynamic? This is A and this is B. What is A? What is B? Both are 𝐒𝐿-𝐄𝐝 splints. But which one is A static? Which one is dynamic? Yes, faster. So this is supposed to be your static 𝐒𝐿-𝐄𝐝 splint. Yes, this is your dynamic 𝐒𝐿-𝐄𝐝 splint. Dynamic is movement, right? So you have springs. Yes, A is static, B is dynamic. Very good. So B is dynamic because springs are there and you see this is dorsal side, the springs are there. So this will help in wrist extensions and finger extensions. Very, very careful. There is one more which is called as Воркман splint. Воркман splint, you will see the springs on the volar aspect because that will cause, that has to do flexion like this. It will do flexion and then it will cause the more flexion of it. Right, and here they will result in extension. So the springs are on the dorsal side. Be very careful while answering in the exam, right? So this is static splint, this is dynamic splint. So why actually we have to splint it? Can't we leave it like that? Okay, what will happen if we don't splint? Why to splint? To learn the names of the splint, put a lot of effort in answering them. So why this whole process of splint? Yes. So the theory behind it is, yeah, anyways, even if you don't do splinting, nerve regeneration will happen. There is no role of nerve regeneration of the splinting. The splinting actually we do is we provide functional position to the tendons. Right. So what happens is the nerve regeneration will happen on its own there. But once the nerve is ready, the tendons has to be ready to take the action, right? Now, if you don't splint it, the wrist drop, it will be like this. What will happen? All the tendons or the extensors, because there is no work for them, they will contract. Once they contract, they will become like this. So that time when the nerve is regenerated, the tendons are not ready to take the action. So by that time, what we do, by the time the nerve is regenerating, we will put the into function, right? We will tell the tendon to act, so that when the nerve is ready, the tendons are also ready, the action is full, right? So that is the purpose of splinting. You should never leave any part of the body without splinting. Whatever the damage might be, you have to put them in their functional positions there. So there are certain functional positions for each part. For example, if it is a wrist, it should be in neutral position, right? Or it could be a slight flexion, right? So this is for action of eating. So whenever you eat, there is a slight flexion here, right? So even if the nerve is not ready, the tendons are not ready, at least this functional position, if you immobilize, the patient will have little activity with it, right? So that is the functional position. For example, again, foot drop, the foot will drop like this. We can't walk like this, right? So what is the functional position? Again, you put the ankle in the neutral position. So even though it is fixed in that particular position, even though tendons contract in that position, at least you will able to walk with the neutral ankle. But if it is contracted in this position, you can't walk, right? So that is why we splint them. So splinting is very, very important to maintain the functional position of the joints, right? And the tendons also, they will not become contracted, or they will not die, at least they will have some movement which can be acted soon upon when the nerve is regenerated. So that is the action of the splint. So that is why if you see the static splint and the dynamic splint, what we are doing, instead of the wrist falling down like this, we are getting in the neutral position, or at least we are trying for little extension movement. Okay, got it? Very good. Sometimes I find your got it, being sarcastic, like it is like, okay, ma'am, we got it. Can you please stop explaining? It sounds to me like that. So next, after radial nerve, it is ulnar nerve. So first one is your radial nerve, and next is your ulnar nerve, which is again, important. So ulnar nerve, if you remember, it is again, so ulnar nerve, it is again C8 and T1. It is a continuation of the lower trunk, if you remember, the brachial plexus. And now here you see it courses along the medial condyle of the humerus, right? And this is supposed to be one of the most superficial peripheral nerves, right? So you can feel the ulnar nerve on the medial aspect. So if you flex the elbow at 30 degrees, and at the medial condyle, you can feel something which is very rubbery and it is moving along with your hand. So that is your ulnar nerve. So you can feel that ulnar nerve, it is on superficial side, and it is mainly on the medial aspect of the forearm as well. And what is the special name of the ulnar nerve? It is also called the it is called the musician's nerve, right? Why it is called the musician's nerve? Because it is all related to the fine movements, right? Hand, intrinsic muscles, most of the intrinsic muscles of the hand are supplied by the ulnar nerve. What do you mean by the intrinsic muscles of the hand? Yes, what do you mean by intrinsic muscles of the hand? So intrinsic muscles of hand, most of them are supplied by the ulnar nerve. Hence these ulnar nerve are mainly for the fine movements, which usually are done by your musicians. So they require all these fine movements, right? Whatever music instrument you take, they usually require this hand very soft skilled, right? So that is why this is called as the musician's nerve. Yes, interosseous are one of the intrinsic muscles of the hand, but I'm asking you, why the word intrinsic? So intrinsic muscles are what? So the first intrinsic, lumbricals are intrinsic, palmar interossei, dorsal interossei, thenar, and hypothenar. All these are intrinsic muscles of the hand. Very, very important. So what is the reason why they have called the intrinsic? Intrinsic matlab, it is they take origin in the hand and they get inserted in the hand. So they don't cross the joints. They don't cross the wrist joints. So if you take anything, like you take lumbricals, palmar interossei, dorsal interossei, thenar, hypothenar, all they take origin in the hand and they get inserted into the hand bones. Origin in the hand bones, insertion in the hand bones. Hence these are called, they are only in the hand. So hence these are called the intrinsic muscles of the hand. There are 5 groups: lumbricals, palmar interossei, dorsal interossei, thenar, hypothenar. All these are the intrinsic muscles of the hand, and most of them are supplied by the ulnar nerve except for your thenar, right, and lumbrical. Thenar and your first and second lumbrical, except for these two, all are supplied by your ulnar nerve. Hence this is very, very important nerve in case of your hand. So these are all the muscles. So if you see in the forearm, it is 2 important muscles. So one is flexor carpi ulnaris and half of flexor digitorum profundus. This you have to remember. FCU and that too medial half of FDP. Right? And when it comes to the hand, I told you it supplies most of them. So interossei muscle it supplies, and then your lumbricals, 3 and 4 lumbricals, and then your dorsal interossei, palmar interossei, both, and then your hypothenar muscles, right? Hypothenar. And now can you tell me, it also supplies 1 thenar muscles, very, very important, exception, res. So this is very important muscle. It is a thenar group, but it is supplied by the ulnar nerve. Which muscle is that? So something like this is very interesting for the examiners as well. No, they keep asking questions only on this muscle. So what is that muscle? Thenar group, but supplied by the ulnar nerve. Faster? Yes, adductor pollicis. Very, very important. You have to remember. So this is a thenar group which is supplied by the ulnar nerve. This is your adductor pollicis. And now coming to the, yes, very good. So coming to the sensation. So ulnar nerve, as you all know, it is the 1.5 nerve. So 1.5 finger it supplies. So this is the 1 finger completely and a half finger. So this is the ulnar nerve. So this is 1 finger and this is the half finger. So this 1.5 finger is by the ulnar nerve. So these are the sensations which you have to look for in case of your ulnar nerve. So this is your ulnar nerve. Right? And then this is your radial nerve. Radial nerve, we know this is only the dorsum which is supplied. So this is the sensations which you are looking for. So ulnar nerve is this 1.5 front and the back. And then dorsal, radial nerve only the small web space, right? So this small first web space is the radial nerve. That's it. Then the rest is all median nerve. This is all median nerve. 3.5. 3.5 fingers is your median nerve, right? So that is about the sensations, right? And then what is this? What is this? So you can see there is an hyperextension of the MCP and flexion of the IP. So what is this called? This is a classical. Yes, answer it properly. This is a classical partial claw hand. This is, yes, partial claw hand or ulnar claw hand. Okay, anything is accepted. So this is a partial claw hand, right? So what else you can see? So once this patient has come to you, for example, so on the deformity, you will write claw hand. And now you will write wasting of the muscles. So you can see there is an hypothenar wasting of the muscles. right? So this is what I have told you, the pro forma. So once you see, then you will look for the skin compared to the, it may look little dry also, right? So this is the, if you see the hypothenor wasting, so this is the hypothenor wasting, this is thenar muscles, this is hypothenor wasting, right? And on the dorsal aspect, you can see there will be intraossei wasting also. So this is a partial claw hand, right? And then what are these tests? So now you have individual muscle testing we are doing. So we are doing testing for the palmar intraossei. And then we are doing for the dorsal intraossei. Right? So what is this test called? We have already learnt it. Yes. This time I want you to answer correctly. Palmar intraossei, I am asking you. Palmar intraossei, what test is this? Faster, faster. Palmar intraossei, I told. Okay. So I will accept. So first one is 𝐒𝐿𝐿𝐴. Yeah, 𝐒𝐿𝐴. Then this palmar intraossei. What is this test? This is your, yes, card test. Very good. So now card test. So one thing you observe, you have to put equal hands, right? The same hands to be used by for testing your card test. So that is your palmar intraossei for adduction. This is your dorsal intraossei for abduction. So this is your abduction. And this is for your adduction. Right? Very, 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 very important. Okay. And then what is this? What is this? So I have told you that there is one important muscle which is being supplied by your ulnar nerve, which is called as the adductor pollicis. So what does this adductor pollicis do? It will adduct, right? So this is tested by what is called as the book test, right? So book test. So what is book test? It is similar to card only, but what we do is we hold the book this way. Right? So we are holding the book this way. You can see. So we are holding the book. So whenever your ulnar nerve is weakened, what happens is, now anyways you want to hold it, right? You will not leave the book. But what we do is, instead of adducting, we use the flexor pollicis longus. So this flexor pollicis longus is used. But this flexor pollicis longus, whenever we use, it will cause flexion of the IP here. So this is bending of the thumb. So flexion of IP of thumb. So whenever you see the flexion of IP of the thumb, this is called as the Fromen's sign. So this is called the Fromen's sign, right? And this will tell you that there is an ulnar nerve palsy. Right? So this is also test for your ulnar nerve, and this test is called the book test. And whenever you can't adduct, you will flex the thumb to hold the book. We are not going to leave the book. So this flexing of the thumb, that is your interpharyngeal joint, is by flexor pollicis longus. And now whenever you use this flexor pollicis, that means that there is an ulnar nerve palsy. Right? So this is the book test. And what is the sign called? This is your Fromen's sign. Very, very important again. Right? So this is your Fromen's sign. So then the examiner will ask you what is Fromen's sign. If you answer, then they will ask you which nerve is supplied by it, right? Very good. Next. So now this is the wasting I have told you. So if you can clearly see, this is the hypothenar wasting. So this is the wasting of the muscles, and these are the intraossei wasting, right? So this intraossei wasting on the dorsal side, intraossei, and this hypothenar wasting on the palmar aspect. You see the palmar hypothenar muscles. So this is your wasting, right? So that is how you have to write in the exam. And once if you have answered all this correctly, Everything you have answered 100%. Then the distinction mark will be given to that person who answers what is ulnar paradox. Okay, so I wish all my students to be a distinction students. So now you will tell me what is ulnar paradox. What is ulnar paradox? So I will just tell you two words regarding this. Whenever you tell there is ulnar nerve palsy, so usually we are talking a low ulnar nerve palsy, right? That means damage at the wrist or forearm. That is below elbow, right? So now what you see here, you see a claw hand. Very prominent claw hand. Actually, why this clawing is happening? Because there is a damage to your lumbricals and the introstia, because low ulnar nerve palsy, so all the intrinsic muscles are damaged. So what will happen? It will result like this into the flexion. So, but this flexion is prominent because there are two important flexors, FCU and FDP, which are pulling the flexion of the IP. These are not damaged. These are not damaged. Understood? Hence, you can see more flexion like this, right? So that is your claw hand. But if at all imagine this particular ulnar nerve palsy had happened at a higher level, that means something above elbow, which has damaged FCU and FDP. So now you see less clawing. Okay, now what you see? You see now you see less clawing. So whenever it is low ulnar nerve palsy, clawing is more. Whenever it is high ulnar nerve palsy, clawing is less. That means whenever the FCU and FDP are damaged, you see something like this. There's not much clawing is there. So you will see that the clawing is not much, and then you will think it is a, ulnar nerve has not been damaged much, hence there is no clawing. But in reality, it has been damaged at a very high level where all the forearm muscles and the hand muscles have damaged, right? So that is why this is called as ulnar paradox, right? When it is low, somewhere at level of wrist or somewhere in the forearm, because the FCP and FDU action is more, there is more flexion of the IP. And now because the FCU and FDP are also damaged, it will result in less clawing. So this is called as ulnar paradox. Is that clear? Any doubts? Very, very important for you to get distinction in Viva. Got it? Now I want to see the got it messages. Very good. Clear. Then what is this? Got it. Good, good. Now what is this? This is your knuckle bender. Knuckle bender splint. This knuckle bender splint is used for your ulnar nerve palsy. So we know that ulnar nerve is MCP extension and IP flexion. So here what is this knuckle bending doing? Bending the knuckles. That means it is resulting in MCP, that is metacarpopharyngeal joints flexion, and IP extension. So that is what you have to understand here. So this is your knuckle bender where it is bending the knuckles. So it is actually causing what? The action of the lumbricals. So that is flexion of the MCP and extension of the IP, right? So this is the concepts that is you're learning behind, not just identifying this image and putting it in mind, right? So what is knuckle bender? Knuckle bender is mainly your clawing. It is correcting your clawing. Clawing is exactly opposite, right? It will result in MCP extension and IP flexion. So what is this doing? This is doing the reverse. It is flexing the MCP and extending the IP. So that is the functional position of the hand. Got it? So this is your knuckle bender splint for your ulnar nerve palsy. Yes, then comes the median nerve. So we have done the ulnar nerve. So median nerve is a bit easy because median nerve is called the laborer's nerve. Why laborer's nerve? Because it supplies all the forearm flexors, right? Not all the intrinsic muscles. It is the that big muscle, the forearm flexors. So all the superficial deep forearm flexors of the arm are supplied by the median nerve. Yes, and then in the hand they supply the lumbricals, that is 1 and 2, and your thenar group. Thenar group except your adductor pollicis. Right? Yes. So this is all the muscles supplied all on the thumb, index, and the middle finger. So whatever is related to thumb and the index is your median nerve, right? Except the Fromen's sign, except the Fromen's sign. So here we see what is called the, yes, that is your ape thumb deformity. So what is the ape thumb deformity? So what happened is, whenever in the evolution, we have evolved from monkeys, right? So apes. So what happened is, in the apes, what we have this as like this. They also have 5 fingers, but this thumb was in same plane as the other fingers. So it was like this. But as we have evolved in the humans, what the God has done is, he has brought the thumb in a very special place, which is perpendicular to this 4. So this is the plane of the thumb for human beings, but for the apes it is like this. So whenever there is median nerve palsy, they're going back to the ape. That is, thumb is again seen in the same plane of the other finger. So that is called the ape thumb deformity, seen in the median nerve. Very good. And then what is this test? And now, because we have told you the thumb has certain important role, because it is very important that it moves in all the directions. So this is adduction, abduction, opposition, right? It does all these actions. So we are testing the thumb abduction here. So this is done by the abductor pollicis, and this is your pen test. Yes, very good. This is the pen test. So how you do? Thumb like this, and then you place the pen exactly here in center of the palm, and it has to come and touch. Okay, so that is your abduction. This is your pen test, where it is the abductor pollicis. And then what is this? This is nothing but your pointing index. So what is a pointing index? Pointing index is, so again back to the basics. So I have told you that all the flexors are supplied by the median nerve, right? That is, FDP and FDS are very important here. So little and ring finger, FDS, FDP are working fine because there is no problem. These 2 fingers, if you see, you cannot just do it like this. You know, this is something related to the other 3 fingers, right? So thumb is independent. So what is happening is, this index finger is entirely supplied by the individual flexor, right? So these are connected. So the middle finger is somewhat this connections has with FDP and FDS, but the index finger is individual. Hence, whenever you have this, so there is this index which is pointed. So this is called the pointing index, because the flexors of this is completely damaged, right? So this is called the pointing index, right? Oh, thank you so much. So this is called the pointing index, right? And there is one more name for this. What is that called? Orthopaedic clasp deformity. So again, we are forming a clasp like this, and then you see that the index finger is not completely flexing, right? So this is called the Ochsner's clasp deformity. And one more thing is the Pope's sign or the benediction. Again, I have told you the flexors are little arranged because FDP and FDS are the extensions, right? They come here and they divide like this. So that is why the flexors are like this whenever the median nerve has been paralyzed. So when you're trying to make a fist, it comes like this. So this is like the Pope's sign. So this is called the Pope's sign. Yeah, Pope's sign or the benediction. Pope's sign or the benediction sign. These are all very, very important. You have to remember for the median nerve. So one is pointing index, Ochsner clasp deformity, benediction, or the Pope's sign. Right, so there is an interesting question for you. This was asked by a student. Now, how will you differentiate this with the claw hand? So this is somewhat appearing like the claw hand also, no? So is this a claw hand or the pointing index? What is your answer for this? This was asked by a student. So that is why basics are very, very important. So in this, what is happening? There is complete flexion, right? MCP is completely flexing here. But what is claw hand? MCP is in extension. So that is what you have to be sure. So whenever there are showing you a picture of something, if it is a Pope sign or benediction sign, see that the entire MCP is flexed. But if it is a claw hand, it is like this, right? Claw hand is like this. So there will be MCP extension with finger flexion. Okay, is that clear? I will remove this. Again, you will get confused. Okay, that is just a doubt. Okay, now that is about the median nerve. Pointing index, Ochsner's clasp deformity, Pope's sign or the benediction sign. And one more interesting thing is, yes, clear. And then this is your thenar wasting. So I'm showing you all the wastings that very, very important, right? So I have showed you the hypothenar wasting, I have showed you the intraosseous wasting, and now this is your thenar muscle wasting, right? So this is very important for your nerve injury. So wasting of the muscles is very, very important and you have to document it, right? And then finally, what is this? This is okay, we have learned in detail. Then what is this? Very important. So appreciating someone is very important, right? You need to appreciate them, as Dr. MBBS has appreciated me that I'm making the topic so interesting. So like that, we all need that appreciation to thrive in life, right? So to have this quality of appreciation, they say you should have good heart and also what? Anterior interosseous nerve. Can't flex thumb. He's flexing the thumb, right? But what is happening here? He's not able to opposition. The opposition is not proper. So like this, he has to form a complete circle. So whenever there is anterior interosseous nerve palsy. By the way, what is this anterior interosseous nerve? So median nerve as a branch which is called as anterior interosseous nerve. Similarly, the radial nerve which has a spin, no? Radial nerve branches posterior interosseous nerve. Median nerve branches anterior interosseous nerve. Right? So this nerve is responsible for proper opposition of this thumb. So whenever they are able to properly oppose it, this is called opposition, touching the tips of the fingers. The thumb will go and touch all the tips of the fingers. So whenever it is touching the tips, you can see a complete O, right? So if it is not touching, so this is what is called, this is pathological. So the oval is not, so this is called as the O sign, or the fancy name to it is 𝐒𝐿𝐿 sign, right? So this is 𝐒𝐿𝐿 sign and this is your O sign or the 𝐒𝐿𝐿 sign. Yeah, he's my rock also. Right? Okay. Now we are done with what? Median nerve. Starting from the eighth term deformity, we have seen the pen test, and then we have seen the benediction sign, the Pope sign, pointing index, Oshner's deformity, O sign, Kilonevin sign. This is all you have to remember for median nerve. Okay? This is what they will ask you. And finally, we will end up with the sciatic nerve. So what is the sciatic nerve? It is one of the most important nerve on the posterior aspect of the lower limb, right? And what I am interested in this is the CPN part, the common peroneal nerve. Ironically, even though the sciatic nerve is damaged, it will result in CPN nerve damage. That is the common peroneal nerve. Right? So this is the common peroneal nerve. And what is the importance of it? So this is your sciatic nerve, and it comes right from the hip joint to the ankle joint, right? And one important syndrome which is associated with this is your piriformis syndrome. This is your piriformis syndrome, right? So this is a muscle which is piriformis, and because of that it is divided into two. Right? So now whenever there is an compression of this nerve at the level of the piriformis, this is called as piriformis syndrome, right? And then coming to the common peroneal nerve. So this common peroneal nerve, it is a branch of sciatic nerve, and where do you usually found it? It curls around the neck of fibula. It curves around the neck of the fibula, and this is very important question which was asked in the NEET PG. So they have put up this exact image, and then they have put this arrow mark, and they have asked you which nerve is damaged here. So this is the common peroneal nerve which is damaged, right? And if you see, this supplies all the extensors and the lateral compartment, that is the peroneal muscles. Extensors and the peroneals are supplied by the common peroneal nerve. Whenever there is a damage to it, what will happen? So then whenever there is damage to CPN, what happens is the ankle goes into, so there is loss of dorsiflexion and eversion of foot, right? So whenever there is loss of this dorsiflexion and eversion of the foot, what is called as foot drop. And what is the interesting factor of the foot drop? Then they will ask you the gait. So whenever there is a foot drop, how will the patient walk? So that is what is important question here. So this is called as the high stepping gait. High stepping gait. So what happens here? So see, so this is the normal foot which is neutral, and this is your plantar flexed foot. So now you have to walk, so you have to dorsiflex and put again next step. So how we walk? We put dorsiflex, heel touch, and then we put, no? So here what is happening is the patient cannot dorsiflex. So what he will do is he'll lift the entire leg and then put it like this. He will lift the entire leg and then he'll put it like this. So because of that, it appears to be having the high stepping gait. So the steps are very high. He will lift the entire leg and put it down. So hence the foot drop gait is your high stepping gait. And what is the splint which we use here? Yes, equinus. It will go into equinus. Very good. This is your foot drop splint. Yes, high stepping gait. So this foot drop splint is used for foot drop. As I've told you, splinting is for functional position. So now if you see, we have put the foot in the neutral position. This is the neutral position of the ankle, right? So that is the importance of this splint. So CPN, very important. It applies all the extensors and the everters, right? So that whenever there is a damage, and most commonly it is damage around the neck of the fibula. So fracture neck of the fibula, or you know, it even in the knee dislocations you will see that there could be a damage to your common peroneal nerve, and this is resulting in what? It is resulting in the foot drop, which will result in the high stepping gait, and this is the foot drop splint, which we have to use as the treatment, right? Okay. So I think that's it. We have learned so much today. So this is the clinical corner which we have come up recently in the PW. So you can see, open the app PW, you will find a corner, clinical corner. Then you have to open the particular subject. Then you will have the individual topics as well. So if you want to read only about the osteomyelitis case, it is given clearly there. So you can go take the help of the clinical corner and do your clinicals. Very good. No, not only the theory, not only NEET PG, we are here to help you to pass your prof exams as well to become a good doctor. Okay, thank you so much. I've enjoyed so much teaching you all. If you have any queries, any doubts, you can text me on Insta, Dr. 𝐒𝐿𝐴𝐂𝐝 Ortho, or directly to PW MedEd. And we have various Telegram channels where you can follow for direct interactions with all the faculties, all the 19 faculties as well for your doubts. Yes, it is possible. We are conducting this success celebrations, no, every time. Then that time you can come and meet Alekhya and all the faculties. It is very much possible. Okay, good night. Thank you so much. See you all in the next class. Bye.